Good afternoon, everybody. Thank you so much for the kind introduction. A huge big thank you to Dr. Harjeet and entire team and KD Hospital for inviting me to be here. So I'm going to be talking today something that is very, very important and pertinent to our country. Diagnosis of TB, do's and don'ts. So let's start our talk with this case. So Ram Prasad, a 42-year-old male, a diabetic with past history of TB 10 years back, for which he had taken DOTS. That was a time when they used to give thrice a week AKT alternate days. So that's what he had done for 10 years. And then he presented with fever, cough, anorexia, weight loss of 1 month duration. He went to his local doctor. So correctly, the doctor did a chest x-ray. He did CBC, ESR. So the chest x-ray showed a right upper lobe patchy consolidation. ESR was 70. A Mantoux test was done, which was positive. So the patient was suspected to be having TB, and he was put on EHRZ 4-drug AKT, and the oral diabetics were continued. Is this approach correct? Yes or no? Perfect. All of you all are right. So diagnosis of TB, there are certain points to remember. The approach that was taken was not correct. So the role of ESR and CRP, we need to know that these are non-specific markers of inflammation. They will come positive in any infection. So if the patient is diagnosed to be having something, it could be CTD, it could be anything. So you can just monitor ESR, CRP for response of treatment. However, you cannot say that this ESR is high, so the patient has TB. The second thing is Mantoux test, TB Gold test, the IGRA, blood IgG, IgM for TB. So we need to know that our country is endemic for TB, and presence of positive Mantoux, IGRA positivity, everything just says that the patient is infected with TB. This doesn't necessarily confirm diagnosis of TB, and therefore Mantoux has no role in starting AKT for the patient. Chest X-ray was really relied upon for this patient. So we need to know that chest X-ray is a very important investigation for a patient of TB. However, it's alone not diagnostic of TB. So let's look at this X-ray. The X-ray is showing right upper lobe cavity with patchy consolidation. What's the most common diagnosis? TB in our country, yes, but this turned out to be squamous cell CA. Now let's look at this X-ray. So we are seeing these fibrotic opacities, some cavitatory, there's loss of volume. We would be so sure this is TB, but this was actually sarcoidosis. Let's look at this X-ray. Over here, this patient was a diabetic. Over here, left mid-zone, lower zone, there's a patchy consolidation, there's cavitatory lesions. So we would be like sure that this is TB, but this was actually nocardia. Let's look at this X-ray. Over here we are seeing bilateral fluffy opacities. We would be so sure that this is TB alone. However, this was lung metastasis. Let's look at this X-ray. We can just swear our lives and say this is miliary TB, but this was actually hypersensitivity pneumonitis. So what I want to say is that TB is extremely important, chest X-ray is extremely important in diagnosis of TB, but basically so many X-rays could exactly look like TB, but they need not be TB, and therefore though X-ray is important, X-ray is not enough to diagnose TB, and a positive sputum AFB smear from a good laboratory is equally important. So the problem was that our patient was not bringing out sputum, and that is the reason he was put on empirical AKT. So if the patient doesn't bring out sputum, then what do we do? Yeah, excellent. So we can do sputum induction by giving nebulized saline. Of course, if there's a bronchoscope easily available, we'll do bronchoscopy. However, if the patient is in the periphery or something, if there's no access to a pulmonologist, then sputum induction with nebulized saline could be done. If normal saline doesn't help, then 3% hypertonic saline is also found to be extremely useful for sputum induction. So coming back to our patient, he was given nebulized saline and he could bring out sputum, but not of great quality. The AFB smear in the sputum was negative. Now what? Does this rule out TB? Do we do something else? Excellent. So we need to remember that AFB smear to come positive requires 10,000 bacilli per ml of sample, and often people's sputum may not be of great quality. It could be early TB, it could be extrapulmonary TB, or it could be a child who's not bringing out good quality sputum. So if it's a postbacillary disease, when the number of bacilli are less than 10,000 per ml of a sample, then even if it's TB, then sputum AFB smear will come in negative. We may say then let's do AFB culture by TB midget. So we know that TB midget is the gold standard currently with the diagnosis of TB. However, it still takes 3 to 6 weeks to grow, and 3 weeks then for sensitivity. And of course, we can't wait for so long to start AKT, because the patient is going to end up infecting everybody in addition to his condition worsening. And therefore, we require something faster to diagnosing TB, and this is where the role of molecular tests has come in. And as each of y'all said, Gene Expert was something that we should have done. Most of y'all gave the correct answer. So we know that Gene Expert is an automated cartridge based assay, and within 2 hours it will tell you whether MTB is present or not, and it will also tell you about rifampicin resistance. So not only do you know if the patient has TB, you also upfront know about AKT to start for the patient. We just spoke that AFB culture takes 3 to 6 weeks to come positive. So, out of 100 people, if there are 100 people who are smear negative culture positive, means the bacillary load is less than 10,000 bacilli. So, AFB smear will come negative, culture will become positive. So, out of these 100 people, if they are subjected to Gene Expert, 72 out of these 100 people will be detected to be having MTB on Gene Expert in less than 2 hours. So you all can imagine, Gene Expert is actually revolutionized diagnosis of TB, and it requires only 131 bacilli per ml of sample to work out, as against 10,000 bacilli that you require in sputum AFB smear. So for a patient, Gene Expert was done. Gene Expert also came negative. So now what do? Bronchoscopy, excellent. So finally, bronchoscopy was done for the patient. So the advantage of bronchoscopy is that we are going into the lesion where we are going into the area of the lung which is abnormal, and therefore the yield of bringing out AFB is going to be much better. In addition, if patient is in mediastinal lymph nodes, then TBNA can be done, which can either be conventional or could be EBUS. So bronchoscopy is extremely important in today's day and age, and it is not even counted these days as an invasive test. We call it minimally invasive or non-invasive. It is very, very important. You have to diagnose TB. You have to have either Gene Expert positive or you have to have AV smear positive, because we know that CA lung presents exactly in the same way as TB. The symptoms are exactly the same. The X-ray can look the same. And if we're going to give empirical AKT to this patient, then we'll be losing 3 to 4 months. And an early and operable CA lung can actually convert into advanced and inoperable, and it can actually cost the patient his life. So we cannot start empirical AKT in today's day and age. Another condition is sarcoidosis. Patient will have all the typical symptoms. The radiology will keep on worsening. The AFB smear keeps on coming negative. In such a condition, please think of sarcoidosis. So what I want to basically say is that if the patient can't bring out sputum, please do a bronchoscopy, but do confirm TB before you want to start AKT. Coming back to our patient, AFB smear was positive. Gene Expert showed MTB detected rifampicin resistance seen. So this patient was initially put on EHRZ, but this patient had past history of AKT and he was rifampicin resistant. So had we not confirmed this, then we would have started AKT, which was not really working on him. Not only would his condition have worsened, but he would have gone around infecting the whole world, which is not acceptable. So what I want to really say is that confirmation of TB before starting AKT is very, very important, and molecular tests have actually revolutionized the treatment of TB in today's day and age. Molecular tests are many. We have Gene Expert, we have Gene Expert Ultra, Gene Expert XDR, TrueNat, LPA, pyrosequencing. The advantage of every molecular test is that you can do it straight away on the sample. You don't need to wait till the TB culture comes positive. They are extremely sensitive, very, very specific, more than 95% sensitivity, specificity. You can easily repeat them if there's any confusion. And the best thing is that it offers less biohazard to the person who's doing it. So drug sensitivity also can be done upfront. So molecular tests in today's day and age are absolutely must. So we know about the Gene Expert, we require only 131 bacilli per ml of sample to work out. It will tell you upfront about rifampicin resistance also. It can be used for extrapulmonary TB also. Based on a patient's probe cycle threshold, MTB detection result is reported as high, medium, low and very low. Gene Expert looks for mutations in the RPOB gene which are present in 95% of MTB, and accuracy for detecting rifampicin resistance is as high as 98%. So advantages of Gene Expert, as we said, many. But we know that though it is almost the best test we have currently, there are certain limitations, and as each of you is an excellent physician and clinician, I'd like to point out these deficiencies which we should know about our test. So if the patient is rifampicin resistant, is it possible that Gene Expert will falsely call the patient rifampicin sensitive? So this will happen in 3 conditions. So as we know, rifampicin resistance is picked up by detecting RPOB mutation. So 95% of patients have this, but 5% of patients have mutations which is outside RPOB gene, and therefore the gene expert will miss out this rifampicin resistance. Also, sometimes patients have mixed population. They have sensitive and resistant bacilli in the same sample, especially in people with cavities or people who have taken interrupted AKT. So if we subject the patient to gene expert, then whichever population is more than 65% will be detected, and whatever is less than 65% will not be detected, and therefore you will not know that the patient is mixed population. And this is important because mixed population, if patient is rifampicin sensitive and resistant germs, then we need to treat this patient as resistant TB. We don't treat this patient as sensitive TB. So this is very important. And sometimes mutations are outside codon 533, and if this mutation is present, then gene expert will falsely call this sample rifampicin sensitive. Similarly, if the patient is rifampicin sensitive, can the gene expert call the patient to be having rifampicin resistance? Yes. So there are patients who might be having silent mutations. So silent mutations don't confer clinical resistance, but they anyway show rifampicin resistant. So 2% of people who have silent mutations, though they are rifampicin sensitive, gene expert will give a wrong report of rifampicin resistant. You all may feel now all this only a microbiologist can tell us sitting in a lab. How can we clinicians know this? So yes, we clinicians looking at the report sometimes can actually pick up that this gene expert report is wrong. And this was this excellent paper of 2016, and please look at this report. Normally we see MTB detected, yes, no, and then we see rifampicin resistance, yes, no. So whenever we see MTB detected, we have to look at the load of the MTB, and if the rifampicin resistance is detected and if the load of the MTB is very low, then there's a 50% chance that wrong rifampicin resistance is picked up by this gene expert. I'm repeating, rifampicin resistance detected and MTB load is very low. If the load is low, medium, high, doesn't make a difference. If rifampicin resistance is not seen in very low, no problem. It is only when rifampicin resistance detected and MTB load is very low. Please note, there's a 50% chance that this patient is actually rifampicin sensitive and gene expert has made a mistake over here, and therefore we need to repeat another type of molecular test to confirm the rifampicin resistance, and we need to treat the patient accordingly. So this is a very, very important clinical tip. We all have a habit that when there's rifampicin resistance, we get excited, we send the patient to LPA, but please look at the MTB load. If it's very, very low, then please take this report with a pinch of salt, and before calling this patient rifampicin resistant, we need to do further molecular tests on these patients. So about gene expert, a few points to remember. Negative gene expert does not rule out TB. So this is very, very important because it requires 131 bacilli. So if the load is less, then it does not rule out TB. A positive gene expert does not confirm active TB, because if the patient is already on treatment, we know that this is a PCR test and gene expert will remain positive for 2 years after initial detection. So if the patient has already taken AKT and after 1 year of stopping AKT, we just generally do anyways, just for checking, if we do gene expert and if it shows MTB detected, then please note this could also be dead bacilli, and therefore if the patient has taken AKT within less 2 years, and if the patient does not have symptoms of TB, and if the radiology, chest X-ray or CT scan does not show new lesions, or if the cycle threshold of gene expert is more than 30, then please think that this is not a relapse of TB, and over here you just want to watch the patient and you will go by what the TB culture shows. If the TB culture comes negative, then we know this was just dead bacilli. If the TB culture comes positive, then you have to treat this patient. So again, I'm repeating, gene expert remains positive for 2 years, and therefore in absence of symptoms and in absence of new radiology, we don't have to jump at a positive gene expert and treat the patient. This could very well be dead bacilli. Basically, if the patient is AFB smear positive and if the gene expert comes negative, then it's a little weird, right? Because sputum smear requires 10,000 bacilli, gene expert requires 131. So whenever this happens, sputum AFB smear positive, but gene expert MTB not detected, this is a hint. This tells you this could be atypical mycobacteria, and therefore please investigate the patient from this point of view, because sputum AFB smear positive and AFB not gene expert negative, this is atypical mycobacteria, which is an important clinical tip. After Gene Expert, we have TrueNat, which we are very, very proud of because this was produced in India. A Bangalore-based company did it. So it's very, very similar to Gene Expert 2-hour test, whether MTB present or not. And if it is present, then a second step test is done for rifampicin resistance. So advantages of TrueNat are there, and at the same time there are certain disadvantages. So the biggest advantage of TrueNat is that it does not require continuous power supply or electricity, unlike what Gene Expert requires. So if the patient lives in a city, we would always prefer Gene Expert. Gene Expert is same as CBNAT, which the program provides us with. However, if the patient is in a rural area where there is no continuous electricity, in a hilly region, then we will do TrueNat for the patient, so that we save time on delivering the sample from a periphery to a main place. So also one problem of TrueNat is it is not fully automated. So if the person who's doing it has to be educated, and there could be some man-made errors, and that is the reason if he's in a city, we'll always prefer Gene Expert. But if there's no electricity, over here TrueNat can be really great. So from all this discussion, it's very, very clear that Gene Expert is the best that we have for early diagnosis of TB. Can we make it better? Yes. Now we have Gene Expert Ultra. The program is still not providing, but if you are in private practice, please do Gene Expert Ultra, because this is almost indispensable in today's day and age. So Gene Expert Ultra, what is done is it's an improvised version of Gene Expert. So if you have Gene Expert, you just have to put in a new program and your machine becomes Gene Expert Ultra. You'll need a bigger cartridge, but otherwise you don't need to buy anything new. So whatever were deficiencies of Gene Expert are improvised in Gene Expert Ultra. So basically the thing is that Gene Expert detects only single copy gene. Gene Expert Ultra detects double copy gene. So obviously MTB detection is better. Gene Expert, the cartridge is small. Gene Expert Ultra, the cartridge of detection is double. So you can put in more sample. Therefore, more PCR is available for DNA. And as a result of that, Gene Expert Ultra MTB detection is better. So it has been seen that Gene Expert Ultra requires only 16 bacilli per ml of sample to come positive, as against Gene Expert, which requires 131. So the sensitivity is 8 times more. So this is fantastic. All the deficiencies of Gene Expert in detecting rifampicin resistance are rectified over here. So codon 533 was not picked up by Gene Expert. Gene Expert Ultra picks it up. Silent mutations were falsely picked up by Gene Expert. Over here they are not picked up. Double population was sometimes missed. Gene Expert Ultra picks up double population better. And most importantly, if the patient has bacillary load low, if the MT detected is very low, then often the rifampicin resistance was falsely given by Gene Expert. This doesn't happen in Gene Expert Ultra. So if the MTP load is very low, instead of giving a false resistance, it has a new category called MTP detected trace. And over here the rifampicin resistance is indeterminate. So it tells you do something else, find out the resistance, but it doesn't give you a false resistance. So as you can see, Gene Expert Ultra is excellent. It requires only 16 bacilli. So for early TB, paucibacillary disease, for extrapulmonary TB, for children who can't bring out sputum, this test is absolutely fantastic. The sensitivity is so much more. There's only a problem that specificity is slightly lost. That specificity loss of Gene Expert Ultra is 2% more than that of Gene Expert, but over here again there's no problem. We know what to do. Just like Gene Expert remains positive for 2 years, Gene Expert Ultra remains positive for 7 years. So if the patient has had history of TB in last 7 years, then you want to be careful. You want to look for symptoms, you want to look for new radiology. However, if the patient has not had TB in last 7 years, then there's no reason why not to use Gene Expert Ultra in today's day and age. If it's extrapulmonary TB also, then although the program is all about Gene Expert, but Gene Expert Ultra has revolutionized diagnosis of extrapulmonary TB also, especially pleural TB. So the thing is that, this is an example of a patient. This young girl had lymphoma, and she got pleural effusion, and tapping was done and the fluid was hemorrhagic. So we were really wondering if the lymphoma had come back, and in the government setup Gene Expert was done, MTB not detected. We were thinking of thoracoscopy, but we did Gene Expert Ultra and MTB was detected. So we could actually avoid thoracoscopy in this patient. So Gene Expert Ultra is really very, very useful. After this, I'd like to come to line probe assays. So line probe assays are unfortunately not very extensively used, but they are absolutely fantastic in diagnosis of TB. We have LPA first line, which tells you about resistance to INH rifampicin. It also tells you about resistance to ethionamide and high dose INH. And also we have we have LPA second line, which tells you about resistance to injectables like kanamycin, amikacin, capreomycin, and it also tells you about resistance to levofloxacin, moxifloxacin, and high dose moxifloxacin. So you can see LPA tells you about 9 drugs up front in less than 48 hours. And if the patient is double population, then LPA definitely picks it up, which is a huge advantage. So what I want to say is that LPA is so much better. Like for example, in Bombay, LPA costs 1800, whereas Gene Expert costs 2200. So LPA is actually cheaper. It tells you about 9 drugs. It tells you about mixed population, but we don't use it. Why is that so? So that is because initially initially LPA required to be done only on either MTB culture positive samples or when the AFB smear was positive, and therefore we had to wait for culture to become positive or possibly disease samples. We could not do it, but now we have LPA version 2, and also if the patient has a negative smear, LPA actually works out and can be done. So the thing is that if the patient's AFB smear is positive, you don't need to do Gene Expert, you straight away do LPA. If the AFB smear is negative, you can do Gene Expert, confirm TB, and even on AFB smear negative status, LPA will actually work out. So LPA is again a very important test. I'm just going to finish my talk. We have Gene Expert XDR, as you all know. That also tells you, in addition to rifampicin will be told by Gene Expert, and Gene Expert XDR will tell you about INH, quinolones, and aminoglycoside resistance. So I'm just going to end my talk with this case. So this patient, the sputum showed rifampicin resistance on Gene Expert and also on LPA. However, the TB culture midget finally showed that the patient was rifampicin susceptible. So what do we treat this patient as? Because there's discordance. So what to do? So this is a time we'll do pyrosequencing. So whenever there are discordant results between phenotypic and genotypic results, that is the time we do pyrosequencing. And of course we have whole genome sequencing, which is going to be the game changer, which is going to tell us about every possible mutation for every possible drug, which is still not officially introduced in our country. So I've given a lot of information. Let me consolidate everything in the form of take-home messages. There's no role of ESR, MANTU, TB Gold, TB IgG, IgM in the diagnosis of active TB. Molecular diagnostics have revolutionized the diagnosis of TB. Gene Expert is excellent, requires only 131 bacilli, but in certain conditions, rifampicin resistance is wrong. That is the time Gene Expert Ultra will come to our rescue. Also, it requires only 16 bacilli per ml. And therefore, if the patient has not had TB in last 7 years, then there's no reason why we should not be using Gene Expert Ultra. LPA is an excellent test to combine, and it will also tell you about INH, quinolones, aminoglycosides, which is very important. Whenever there's discordant results between phenotypic and genotypic sensitivity, pyrosequencing will come to our rescue, and whole genome sequencing is superior than every molecular diagnostic test, which will allow us to screen for every mutation of every gene. So there are changing trends in diagnosis of TB. 50 years back, all our seniors, they used to just examine the patient diagnosing TB. Then came chest X-ray, we started looking at the X-ray, we started diagnosing TB. Then came AFB smear, a great test to diagnose TB. Then came solid cultures, LJ media. Then came the liquid cultures, the midget. Now is the time for molecular probes, and therefore friends, as times are changing, we have to keep on changing also, and there is absolutely no reason why not to incorporate every possible molecular tests upfront in the diagnosis and treatment of TB. Thank you so much.